My name is Dorota Gruber, and I'm the principal investigator for Duchenne Muscular Dystrophy Pilot at Norfolk Health. I'll be talking today about our experience during COVID-19 pandemic and the modifications that we needed to implement in order to overcome the challenges posed by the pandemic, so we could continue to do the pilot despite the difficulties. Just to give you a little overview, Duchenne muscular dystrophy is a genetic X-linked recessive disorder characterized by the progressive muscle degeneration and weakness. It is the most common pediatric onset form of muscular dystrophy. It is caused by DMD gene mutation that results in absence of dystrophin protein, which is required to maintain muscle infrastructure. And this leads to necrosis and leakage of enzyme creatine kinase. The disease primarily affects boys, but it's in rare cases can also affect girls. Incidence is 1 in 5,000 live male births. Babies with DMD have normal appearance at birth. Symptoms onset is in early childhood, usually between ages 3 and 5. This is usually after irreversible muscle damage is already done, and in many cases, other affected siblings have been born. Most children are wheelchair bound by age 12 to 13, and 30% of them might have various degree of cognitive impairment. Heart and respiratory muscle problems begin in teens years, leading to death in early 20s or 30s. It could be also earlier than that. In October 2019, a consortium consisting of New York State newborn screening program, Parent Project Muscular Dystrophy, Norfolk Health Hospitals, New York Presbyterian Hospitals, American College of Medical Genetics and Genomics, Newborn Screening Translational Research Network, Perkin-Elmer, and industry founders initiated a consented pilot study in New York State with the aim of collecting data for consideration of Duchenne as a candidate for the recommended uniform screening panel. The goals of Duchenne pilot were to validate the high throughput first tier immunoassay CKMM, optimize the second tier confirmatory molecular genetic testing, and then using this first and second tier testing algorithm to identify infants who will develop Duchenne before the onset of clinically detectable symptoms. This would allow for initiation of early treatment and participation in clinical trials. The ultimate goal was to use the results of the pilot testing to demonstrate NBS feasibility and to nominate Duchenne to the recommended uniform screening panel. DMD pilot protocol involves multiple steps, including screening for eligibility criteria. We look at the hospital admission for delivery. We also look at the age at delivery to make sure that the mom is 18 years or older. And we also making sure that the baby was born live. Once that's done, consenting process continues, and once consent is obtained, marking of NBS cards is performed. The DMD letters are the sign that the individual was consented to the pilot. Once the card goes to the laboratory, the first year screening is performed, and if the result is negative, no further testing is being done. If the testing is borderline, a repeat specimen is requested. For those patients who are found to be positive on screening test, they are referred to medical genetics for the second tier confirmatory testing, and that includes DMD gene sequencing and deletion duplication, and muscular dystrophy panel. For those patients who are additionally negative, after those two tests, clinical testing as per standard of care can be performed. Pre-COVID enrollment strategy included on-site in-person consenting. Coordinators approached moms in their rooms or in NICU, described the study and DMD conditions of the patient, and addressed any questions that patients might have had. When they obtained the consent, e-consent, the signature was obtained on tablet at the bedside. Once the consent was completed, study coordinators marked Guthrie cards and moved on to the next patient. Pre-COVID screening strategy, tier 1 and tier 2, is presented on this slide. And if for the CKMM below cutoff point, the screen was called negative. For the CKMM in a borderline, repeat sample was requested. And in this situation, study coordinator or study nurse called patients and coordinated repeat sample collection with patients, parents, and pediatrician. If CKMM level was above cutoff point, babies were referred to medical genetics for pre-testing, pre-genetic testing counseling, and the additional sample was collected. And then once the results came back, post-testing genetic counseling was performed, and if baby was found to be positive for DMD, BMD, or other neuromuscular disorder, they were referred to neuromuscular center. In regards to data collection tools focused on neuromuscular disorders were developed in collaboration with Longitudinal Pediatric Data Resource at Newborn Screening Translational Research Network, ACMG, study APIs, and New York State Newborn Screening Program. Expert work group was assembled to draft common data elements, and collected variables included demographics, prenatal history, family history, newborn screening, results, as well as genetic test results, diagnostic data, neonatal outcome, developmental progress, and treatment. A data dashboard to track important pilot findings and trends was also developed. In addition, parent surveys were designed to assess the experience of families enrolling in the pilot. 3 surveys were developed 3 months after a borderline result, short after diagnosis, and 1 year after diagnosis. And this is an example of a data dashboard used to track important pilot findings and trends. The outbreak of pandemic put the study temporarily on hold, and rapid response of the study staff was critical to the ability to continue the pilot. And this is here's the timeline of the events. At Northwell, pilot was initiated on October 8th, and New York Presbyterian October 1st. On March 13, we were informed that Northwell-wide COVID-related closure was in effect, and this was our last day on consenting in a hospital. Outpatients clinics closures were also in effect, except for emergency cases. On March 24th, we were informed about possibility of early discharges. And this is 12 to 24 hours as opposed to 48 to 72 hours pre-COVID. Between March 16 and 26, we worked on modifications of the protocol to allow for remote consenting process. This included rewriting a DMD protocol and e-consent components to accommodate a remote enrollment process, obtaining remote access to study materials and for our staff, obtaining remote meeting software, IRB submissions, remote training of the staff, as well as institutional approvals from each facility to perform remote consent process. On March 27th, we obtained IRB approval of modifications, and between March 27th and 30th, institutional approvals from all participating facilities were obtained. On April 1st, 2020, we launched remote recruitment and follow-up. And this lasted between April 1st and July 12th. And on July 13th, we resumed partial in-person enrollment at Long Island Jewish Hospital, North Shore University Hospital, and Lenox Hospital. And this was hybrid workflow, in-person and remote. On August 20th, we resumed partial in-person enrollment at Southside Hospital as well. Remote enrollment process modifications included hospital census were to be reviewed remotely or for all participating facilities. Newborns were to be recruited via phone, as previously during moms and babies stay in a hospital. Those who were not able to we were not able to contact during their time in a hospital were called after their discharge within the first 4 weeks of life. Tracking of late consents and sending lists of late consents to the state was done. And since we were no longer able to mark the cards, instead we were able to, we were in charge of generating a list of enrolled patients, and the laboratory staff was marking Guthrie cards. Paper consents were sent to the patients with no emails, and those who have had difficulty following instructions. Weekly remote meetings with staff were arranged to go over any issues and to share any strategies that worked. New York State, the laboratory had to adjust as well. Delays in consent affected laboratory workflow. This included receiving daily list of each from each hospital system, releasing routine NBS results to prevent delays, and this is without DMD results, manual scheduling DMD tests, pulling specimens for short-term storage from storage, releasing amended reports, including DMD screening results. Borderlines reports were modified to allow collection of repeat samples when practical, and lab had to expect delays for receiving repeats and closing cases, and to expect fewer specimens for screening as well. In terms of remote follow-up protocol for borderline cases, our research nurse was coordinating with baby's pediatrician and parents repeat sample collection, and the delays were present until the delays were in follow-up were acceptable until convenient for the family. In terms of a second tier follow-up, which launched on April 1st, clinicians had to undergo training and to obtain access to Northwell telehealth services, Amwell platform. They utilize Amwell platform to see patients for the follow-ups. They were getting verbal consents for genetic testing. PDF file of consent was emailed to the patient. Once the consent was back, a sample collection kit was ordered via laboratory portal or sent directly from the Office of Medical Genetics. Once received, parents was to collect the sample and send it back to the laboratory. Follow-up telehealth visit was scheduled to review the results. And once, if the results were positive, referral to neuromuscular clinic and family tested as needed was performed. And all of these were delayed and until it was convenient for the family. Once the closure of in-person research was partially lifted, we were able to go back to the floors and restart a hybrid in-person and remote consenting process and follow-up. And consenting process included daily COVID-19 symptom monitoring, temperature checks and mask shields had to be worn at all times, remote daily review of hospital census, daily in-person enrollment at each site was present in each hospital. To minimize the time in a hospital, the coordinators would consent patients in a hospital and then continue the data entry at home. When census was low, calls were made to patients who were missed during before their discharge. The discharges which were during the weekend, holiday deliveries, COVID positive patients needed more time to decide. For the follow-up, in-person and telehealth visits were available to all participants and their families, and blood samples or buccal swab samples collection was available as well. This slide shows our recruitment from October 1st, 2019 to March 31, 2021. And as you can see, between March 2020 and July and June, basically June 2020, we enrolled about half of the patients that we would enroll in a in-person pre-COVID time. And after July, we actually went back to the pre-COVID numbers and even exceeded the pre-COVID numbers, and that continue until November, December, and January. And there was a little dip during those months due to the fact that due to the holidays and the fact that the coordinators were taking some time off. But we went back in March and April. We went back to high enrollments, even exceeding the numbers from the pre-COVID. So just to give you a little idea where we are now, this is pilot data from October 1st, 2019 and April 30th, 2021. At this point, we screened, a number of specimens screened is 30,596. A number of babies screened was 28,029. Of those, 50.9% are male, 49.1% are female. Reported borderline, we had 251 babies, 1 in 112 babies were reported to be borderline. Of those, 61% were male, 59% were female. We received 235 repeated samples and 12 moms declined the redraw. We are still waiting for additional 4 to come back. As far as referral, we had 30 infants being referred to medical genetics. 17 of those were males, 13 were females. We identify 4 patients, confirmed diagnosis of DMD and BMD, and we identify 1 female carrier. Just to summarize major challenges that we encountered so far were staff burnout. This was due to isolation, frustration with the process, multiple calls being made to the patients, and long time on the phone with each of them. No vacation. There were no plans for vacations. Hospitals were coping with pandemic. There were constant changes in the hospital protocols, and we had to comply with each of them. Technical and software glitches, especially during the beginning of the pandemic, during the beginning of the process, the remote process. Computer illiteracy requiring extensive instructions for subset of our patients, no access to email for some of the patients, paper consent mailing requiring substantial resources and follow-up and turned out to be non-sustainable. Shipping delays leading to the delays in sample analysis and result disclosures. And points to keep in mind, the really learning points were importance of being flexible, persistent, and think outside the box. Sharing what works with other team members was the key. Importance of having a buy-in from the leadership of the hospital as well as IRB. Mindfulness of staff well-being. Constant communication between study staff, so team meetings, group text, calls, being close with neonatology group, pediatrics, and study collaborators was the key as well. Education of healthcare providers about the pilot as well as cross-training of staff was absolutely necessary. Importance of redundancy in research protocol. Importance of planning for shipping delays, making sure that patients were aware of possibility of delays, especially with the result disclosure, and the need for providing range of options for obtaining consent in person, online, and phone and paper. And most of all, making sure that we are ready to return to pandemic measures with resurgence of COVID-19. Perhaps the most important point to keep in mind is that the development of a hybrid approach to patient recruitment and follow-up could be applicable to a broad spectrum of future studies and clinical trials post-pandemic. At this point, I would like to thank my Northwell team, as well as our collaborators, Dr. Michelle Pajana, Dr. Norma Travacoli, Sunju Park, Brianna Maloney, and Melissa Pierce from New York State Newborn Screening Program, Duchenne Steering Committee, Ms. Nikki Armstrong, and Ms. Jennifer Ali from Parent Project Muscular Dystrophy, Dr. Wendy Chung and Julia Wynn from New York Presbyterian Hospital, Ms. Annie Kennedy, Every Life Foundation for Rare Diseases, Dr. Amy Brower, Mr. Michael Harnett, and Dr. Michelle Prunier from ACMG, Ms. Hannah Polari from Perkin Elmer, and our industry sponsored. Thank you.